Hello again. Thank you again to the organizers for the invitation to speak today. This has really been a very thoughtful and thought-provoking conference, and it's really been a pleasure to be part of it. This is now the part where we ask more questions, and I will say this question, when and for whom should we be using long-acting INSTIs, are big questions, and I do not profess to know all of the answers, but look forward to our discussion. Again, I have no conflicts to disclose. I will say that I lead a weekly ART conference at our HIV clinic at Vanderbilt. And some of the questions that this talk has posed are questions that are coming up in our clinic. And I'm happy to share with the perspective from our clinic on how we're approaching some of these questions. Okay, so learning objectives for this talk: to describe the indications and currently approved populations for receipt of long-acting integrase strand inhibitors, and also to identify the knowledge gaps in the use and prescription of these medications in people living with HIV. So I'm going to tell you about another one of my patients. This is Mr. P. At the time of coming into care with me a couple years ago, he was 31 years old. He was diagnosed, so this is from a few years ago when I first met him. He was diagnosed with HIV in 2010, and when he came to our clinic in 2020, his CD4 count was 12, and he had a viral load of almost 300,000. He had previously been treated with elvitegravir, cobicistat, TAF, and FTC, but that period was marked with multiple interruptions in therapy. And more recently, he had been treated with bictegravir, TAF, FTC, as well as darunavir, cobicistat. Prior genotypes from his clinic before only showed an M184I. He had PJP pneumonia in 2016, 2018. And really, since 2016, his CD4 count has been less than 50. He's never achieved virologic suppression. He's got a number of comorbidities that also impair his adherence and his ability to maintain medications. So what happened when he came to our clinic? Well, we began with restarting his previous regimen with bictegravir, TAF, FTC, and darunavir with cobicistat, as well as medications for prophylaxis against opportunistic infections. And over the next year or so, we saw him monthly in our clinic. I would see him, and one of our mental health providers would also see him, trying to strategize on how to optimize his ability to take his daily medications. However, he never achieved virologic suppression, and his CD4 count remained less than 50. Genotypes throughout this time failed to show development of new resistance. Unfortunately, in 2021, he lost his job, and he developed housing instability. And in late 2021, he was admitted to our hospital with PJP pneumonia for the third time and esophageal candidiasis because he had stopped his meds after losing insurance and not being able to fill his medications. So questions for this talk: is this patient a candidate for long-acting integrase strand inhibitors? So here's our outline. We're going to review the studies that led to the approval of the first long-acting INSTI for treatment of HIV. We're going to review the populations of people living with HIV who are currently approved and those that are not currently approved for receipt of this medication, and then to discuss the unanswered questions around indications and populations who may benefit from these important medications. So when we're talking about long-acting integrase strand inhibitors, for the purposes of this talk, we're going to be focusing on long-acting cabotegravir and rilpivirine. Cabotegravir and rilpivirine are intramuscular injections of cabotegravir long-acting, which is structurally similar to dolutegravir and has a high genetic barrier to resistance, and rilpivirine, which is a second-generation NNRTI. It's given in a clinic setting every 4 or 8 weeks, and there's an optional 28-day oral lead-in. This slide shows the key studies that led to the approval of cabotegravir, rilpivirine long-acting, and I'll go through the similarities and differences of these studies. So LATTE-2, FLAIR study, and the ATLAS study. So LATTE-2 was a phase 2b open-label randomized non-inferiority study that was conducted in the US, Canada, and countries in Europe. The FLAIR study was a phase 3 open-label non-inferiority study that was primarily conducted again in the US, Canada, Europe, and Japan, and also with the addition of South Africa for a middle-income country. And then the ATLAS study was a phase 3 open-label non-inferiority study, again, 13 countries in the US, Canada, and Europe, and middle-income countries of Mexico, Argentina. The inclusion of all these for these studies were also fairly similar. For the LATTE-2 study, they included ART naive, people living with HIV, who were initially started on an oral regimen of cabotegravir, abacavir, and 3-TC. The FLAIR study included adults living with HIV who had been on dolutegravir, 3-TC, and abacavir for at least 4 months and had undetectable viral load. And that dolutegravir, abacavir, 3-TC was their very first ART regimen, so they hadn't had prior ART before that. And then the ATLAS study included adults, again, living with HIV, also with viral suppression for at least 6 months on an ART regimen other than dolutegravir, 3-TC, or abacavir, so trying to improve the generalizability. The exclusion criteria for these studies were also fairly similar. All studies excluded individuals who were pregnant or could potentially become pregnant. Individuals of childbearing potential had to be on multiple forms of contraception to participate. They excluded individuals with major ART resistance, or for some of these studies, prior exposure to INSTIs or non-nukes. They also excluded individuals with moderate to severe liver disease, and for the ATLAS study, they excluded individuals who had had recent interruptions to their antiretroviral therapy. Individuals in LATTE-2 were randomized to either cabotegravir or rilpivirine long-acting every 4 weeks, cabotegravir or rilpivirine long-acting every 8 weeks, or to continue the oral cabotegravir, abacavir, 3-TC. The FLAIR and ATLAS studies, individuals were randomized to either continue their oral ART regimen or switch to the cabotegravir or rilpivirine long-acting every 4 weeks. So what were the results of these studies? The results were slightly different. For the LATTE-2 study, they looked at the proportion of individuals who had achieved virologic suppression with a viral load less than 50 at week 32, whereas the FLAIR study and ATLAS study looked at the opposite. They looked at the individuals who failed to suppress by week 48 in the snapshot analysis. Overall, you can see as highlighted in the orange boxes below, for the intention to treat populations for all 3 studies, the rates of reaching the endpoint, whether suppression or detectable virus, were very similar between the groups who were randomized to the long-acting regimens or the oral regimens. To statistically compare these groups, all of these studies use a non-inferiority approach and with fairly similar non-inferiority margins, and all 3 met the criteria of non-inferiority with their differences, the 95% confidence interval for the differences not reaching that pre-specified non-inferiority margin. So in January 2021, cabotegravir rilpivirine was approved in the US for treatment of HIV. Since then, we've also had additional studies that have looked into the use of cabotegravir rilpivirine long-acting. The ATLAS-2M study was an extension of that first ATLAS study, but this time it randomized individuals who were in the original ATLAS-2 study to either continue on the cabotegravir rilpivirine long-acting every 4 weeks versus cabotegravir rilpivirine long-acting every 8 weeks. These results were presented earlier this year in CROI, where they compared the virologic outcomes of the intention to treat and per protocol populations receiving every 4 weeks versus every 8 weeks cabotegravir rilpivirine, and found that overall individuals who received cabotegravir rilpivirine every 8 weeks continued to have non-inferiority compared to the every 4-week group at week 52. And both groups had very high rates of virologic suppression at 152 weeks at 86 to 87%. Looking a little bit more into the individuals who failed, from the week 96 virologic failures, there were 2 individuals who met failure criteria, which was defined as having 2 consecutive viral loads greater than 200. Both of the individuals who failed at the week 96 mark were in the every 8-week arm. Both had body mass index less than 30. One person had a subtype B and the other person had a subtype A6. At the week 152, there were 13 failures. 11 of the 13 were in the every 8-week population, 2 were in the every 4-week population. And from their analysis, the risk factors for failure at week 152 included the detection of a proviral resistance mutation, as well as HIV subtype 1A16, or having a BMI greater than 30. So from what we know currently, who is long-acting cabotegravir rilpivirine recommended for? So it is recommended as a complete HIV regimen for people living with HIV who are older than 12 and who weigh at least 35 kilograms. It is a maintenance regimen for individuals who have achieved virologic suppression with an oral antiretroviral therapy first, and it's not recommended as initial therapy. Explicitly, it's not recommended for people who are taking certain anti-seizure medications, nor for people who are taking rifampicins. It's not recommended for pregnant or breastfeeding people. It's not recommended as treatment for people with chronic hepatitis B without some other treatment for hepatitis B specifically. It's not recommended for individuals with severe or end-stage kidney disease, nor individuals with severe hepatic impairment. So a couple of things to keep in mind with the long-acting cabotegravir and rilpivirine. So by definition, these are long-acting medications. And I show here on this table the difference in the half-life elimination comparing the oral administration of cabotegravir and rilpivirine versus their intramuscular long-acting versions. So oral cabotegravir has a half-life elimination of 41 hours versus the IM administration of long-acting cabotegravir, where you have a half-life elimination up to 11 and a half weeks. The difference for rilpivirine is even greater. So half-life elimination for long-acting rilpivirine IM is up to 28 weeks. So what this means is that it takes longer for these medications to be eliminated by the body, and so they hang around for a longer period of time, meaning that potentially there could be a longer period of time where those drug levels are not high enough to control the virus, but high enough for the virus to mutate and develop resistance. This means that it's recommended that if somebody misses their timing for their injection for cabotegravir rilpivirine by more than 7 days, they should be restarted on oral antiretroviral therapy to maintain virologic suppression and not risk developing resistance during these long half-lives of these injectable therapies. Additionally, while the intramuscular administration bypasses the intestine and the stomach, eliminating potential drug-drug interactions or interactions with gut mucosal CYP3A4, it does not eliminate all drug-drug interactions. Cabotegravir is metabolized by UGT1A1, and rilpivirine is metabolized by CYP3A4. And the drug-drug interactions that could still occur at the liver mean that it's recommended to avoid rifampicin and rifapentine for cabotegravir, as well as avoid rifabutin in the setting of rilpivirine. Additionally, as mentioned, there are a number of anti-seizure medications that in particular need to be avoided in the context of cabotegravir. Co-administration with medicines like carbamazepine can lower the drug levels of medicines like cabotegravir and a number of other integrase strand inhibitors. So reduce drug-drug interactions, but not elimination. So other considerations. In general, these medications were very well tolerated in the studies that they have been looked at. And the most common adverse effect was injection site reactions, similar to some of the data that we've seen presented earlier today. Importantly, this regimen is not recommended to be used in combination with other oral ARTs. So we don't know how this regimen might work in the setting of some type of salvage or regimen that includes both the injectables and an oral ART. It's not approved for that use. These medications need to be given in a clinic, and so there's extra clinical demands that would be needed in order to administer these medicines. You would have to have nursing and clinical staff who are available to give the injections, as well as a way to track and maintain to make sure that individuals are able to come to clinic on time and not miss or be late for an injection. And there's also the consideration of cost for healthcare utilization. A single injection of Cabenuva in the United States is about $4,500. So what are some of the unanswered questions regarding use of cabotegravir rilpivirine long-acting? So one question is, when and where should these medications be given? As mentioned, the studies that were performed for their approval were largely performed in high-income settings where there was not high rates of prevalent tuberculosis. And we know that there are important drug-drug interactions, particularly with rifampicins, that could affect how well these medications could perform in settings where TB is more prevalent. As mentioned, the administration and tracking of individuals who are on these medications can be great. And in a study setting where there's those extra resources to provide that tracking and study nurses to give the medicine, it can be feasible. But how does that translate into a real world setting where clinical resources are finite and not always expendable? And then finally, a very practical question about where currently this medication is recommended and approved to be given in the gluteus medius muscles. But what about individuals who can't receive injections there? Do we have any alternatives for other locations where this medication could be given? Additional questions around for whom are these medications most recommended and who do we not have information for? Certainly there are populations that were not included in those initial approval studies. People who could be pregnant or become pregnant were excluded. People with moderate to advanced liver disease, an important population in our clinics, were excluded. There's some concern around how well these medications perform for individuals at the highest BMIs based on some of those failures that happened in the Atlas 2M. Similarly, we have the option of every 4-week versus every 8-week dosing. How do we choose, and for whom do we choose? How do we personalize this decision? And then finally, one thing that we struggle with in our clinic is balancing promoting and elevating patient autonomy and choice in their HIV treatment with real concerns around healthcare utilization and finite resources in the clinic. So this is a commercial that runs in the US, and patients come to our clinic and they ask, hey, I've heard about the injection. Can I get started on the injection? If we can only give this medication or offer this medication to a certain number of individuals because of clinic staff or because of cost, how do we balance the patient autonomy and wanting to support their choice for the treatment regimen that works best for them with what we can feasibly offer to all? And then finally, an important question about availability of these medications for individuals with a history of virologic failure and patients like mine who are the most vulnerable and stand to potentially gain the most from these new therapies. So to answer that question, the ACTG study 5359 is ongoing. This is a study specifically for patients like mine, so individuals who are adults on antiretroviral therapy but have a history of non-adherence or a history of virologic failure. Individuals first all undergo step 1, where they have an intense induction phase, continuing their oral antiretroviral therapy, but with extra study support and financial incentives to get them to the point of achieving virologic suppression. At which point in step 2, they're randomized either to continue their oral ART or be randomized to begin long-acting cabotegravir rilpivirine. And then there's a crossover period and then an observational phase thereafter. This is a really important study which will help hopefully broaden the eligibility criteria to patients with a history of virologic failure and who may really stand to gain from a medication that does not require daily oral administration. So coming back to Mr. P, what happened to him? So late 2021, he's admitted with PJP pneumonia for his 3rd time. And after almost 2 years at our clinic, but years before that, has been unable to achieve virologic suppression. So he was enrolled in A5359 in early 2022. We're eager to see the total results of this study, but I will say from his experience, his enrollment in the study helped him achieve virologic suppression for the first time, and his CD4 count is at least now over 100. So we're looking forward to this study hopefully concluding and giving us important results that may impact the care for him and people like him. So conclusions, cabotegravir rilpivirine long-acting is the first completely injectable ART regimen for maintenance treatment in HIV. The phase 2B and phase 3 randomized control studies demonstrated non-inferiority to oral regimens, and follow-up studies have shown durable virologic suppression using the every 8-week and every 4-week dosing regimens out to 152 weeks. However, the implementation of cabotegravir rilpivirine long-acting in our routine clinical settings is raising very practical questions around when, where, and who will most benefit. And this includes considering perspectives of patients, but also clinic and policy considerations as well. And there are ongoing studies to examine the use of these important medications in populations who have historically struggled with ART adherence and may stand the most to gain. And that's a picture of Vanderbilt, and thank you all. I look forward to the discussion.